afternoon, everybody, and I hope you have not eaten too much so that you don't sleep. Don't put the lights off, otherwise they'll all go to sleep. So, I think we have a small session, and Pandav may or may not come, but anyway, we'll take care of that. So, Pratibha was very, very kind to say that she'll present first. So, so Pratibha is from Aravind, and she is now quite senior, and she has done all kinds of surgeries, and she has uh, been awarded a number of awards, including Dr. Bipasha Mukherjee and Nirmala. Under the guidance of Dr. Bipasha and Dr. Nirmala, she has worked, performing many, many surgeries. So I think she was in plastics as well as phaco. So what basically she is going to tell us is about the modifying ocular blood flow. So we have always been, a little troubled whether actually this ocular blood flow thing really works or it doesn't work, or is it just that the company is filling our head. And how my practice has changed is that initially I used to give brimonidine thinking that it's a neuroprotective. But now, after they have been harping that actually the ocular blood flow gets increased, mentally somewhere or the other you get affected. And plus, brimonidine, क्यों नहीं use करते Surbhi? Why don't we want to use brimonidine as the first drug? No, pressure lowering is good. Side effect. The major thing is there are so many allergies. You start with brimonidine, patient will allergic. Second thing, very important, it doesn't work in the night. Okay, whereas the dorzolamide, brinzolamide works in the night, and now they are telling us it increases the ocular blood flow. So there's another technique of kind of neuroprotection. So that is why we are very happy. And now after prostaglandin or timolol, the third drug that I used to give was brimonidine. So which I have now changed, and I go on to this. Anybody wants to contest that? Any opinions on your part? बोलो भाई बोलो, दिस इज इंटरैक्टिव सेशन, यहाँ कोई ऐसे नहीं है सोने को नहीं मिलेगा. सबसे पीछे कौन बैठा है? So so after, yeah, please go ahead. What happened? Something is wrong? हाँ देखो देखो करो. Who else? Purvi is also going to come later. And okay, let me just, yeah, please. Yeah, whatever time. You see, matlab, that is what the no reason. I'm not really sure about the. Anybody has any idea about what is the reason? But both timolol and brimonidine, they do not work in the night. Sorry? No, you can even use TID. As a matter of fact, we are using, but again, what has happened in my mind now, that if I have to give brimonidine or timolol, I am giving them earlier, so that I will put it 6 and 6. Okay, so that at least, yes, so that we have time till the night. So, and again, same with the timolol thing, because, and timolol again, anybody has any experience whether BD dose is good or OD dose is good? Yes, sir. Very good. You see, yes. So वो भी एक change आया क्योंकि हम लोग आंख बंद करके ना बीडी बीडी then no, company is not telling anything. Company wants us to put 10 times because their drops will be sold faster. But I have seen personally, and Surbi, my fellow, may agree with that, that we have been changing regularly now people from BD dose to OD dose. So what happens is, especially if we talk about, are you ready? Chalo, finally. So, just one thing I wanted to add, that a lot of people give, like, let us say they want to give PG and Timo combination in the night. Okay. Then they say, okay, no, 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 Timo will work better in the day, so let me give it in the morning. But by the main dose of yours is PG, and the PG is best given in the night. Why? Because it is, please, madam, please, you can go out and listen. Huh? So the if the PG dose because most of the Indians get their peaks in the morning, so we want to hit them at that time with the maximal dosage, and that is a PG dose. So I invariably split it up and give this thing in the morning and that in the evening. Oh, usually it will cover 24 hours. You check. I checked so many papers. Anyway, I think she's ready, and please go ahead, yeah. After
Thank
that,
you.
Sunita.
Thank you, sir, for the kind introduction. And thanks to Murli, sir, and Sipla for giving me the opportunity today to present here in front of you. I was part of this study, and Murli sir had given the opportunity to me to present today to you today. So my topic is management beyond IOP control, modifying ocular blood flow, Indian experience. So we all know that glaucoma is a condition characterized by progressive retinal ganglion cell death, which is associated with visual field loss, in which elevated intraocular pressure is not the only risk factor. There are other causes like ischemia to the optic nerve, dysfunctional vascular regulation, which are important causes which causes progression of glaucoma. So literature has enough proof to say that normal tension glaucoma, IOP independent factors predominate like the vascular insufficiency, vasospasm and translaminar pressure difference. These are the more important causes in the progression of glaucoma in normal tension glaucoma. So this is a typical picture of a normal tension glaucoma with the disc changes and the field changes. So in 2007, World Glaucoma Consensus has reported that lower ocular perfusion pressure, lower ocular blood flow, and vascular dysregulation are important causes of progression of glaucoma other than the intraocular pressure. So with all these background, we understand that the retrobulbar hemodynamics is very important. And to understand the retrobulbar hemodynamics, we should, the color Doppler imaging gives us clue about the velocity and the resistive index. So this is a tool to analyze the retrobulbar vasculature. And literature has proven the association of glaucoma progression and visual field loss with reduction in blood flow and increase in resistive index. So the color Doppler imaging can be measured using a GE Sono CT ultrasound system. It's a basically ultrasound principle with a 7.5 megahertz linear probe. And the color Doppler imaging will be taken from the three major important vessels which are responsible for the vascular supply of the optic nerve, that is the ophthalmic artery, central retinal artery and posterior ciliary artery. So the machine measures something called as the resistive index, which is very important. The resistive index is calculated by the formula. The machine calculates the peak systolic velocity and end diastolic velocity, and the machine gives us the resistive index. So this is the machine with which we did our study. And here we can see the right eye and left eye with the values, the peak systolic velocity and end diastolic velocity values and resistive index. We did the study around 5 years back when we didn't have a normative data. So we did a small normative data in our population. And in that we found that the resistive index also increased with age. This is a normal color Doppler imaging picture. It has a peak and a trough. This is a picture of a glaucoma patient wherein there is no peak, there is troughing, and it's not like a normal patient. So with this background, we decided to study the effect of dorzolamide and timolol on ocular blood flow using color Doppler imaging in normal tension glaucoma patients. At the time of our study, there were a lot of proof in the literature which reported that the dorzolamide increases blood flow and it improves the perfusion. So we wanted to study that with the study. So our study was a prospective comparative double-blinded study The radiologist did not know what type of glaucoma and any details about that. Newly diagnosed normal tension glaucoma patients were included. Baseline measurements were done, the glaucoma evaluation and color Doppler imaging measurements, and the patients were randomized into two groups, and they were started in dorzolamide or temolol for 2 times for 12 weeks, and then the final measurement was done at the end of 12 weeks. Glaucoma evaluation and ocular blood flow is analyzed pre and post-op. We included all newly diagnosed mild to moderate normal tension glaucoma patients who were willing for the study and who had a reasonably good vision in one eye. And we excluded patients who had other secondary glaucomas, who had other systemic problem because beta blockers could be contraindicated, and who had undergone intraocular surgery or who had undergone other laser trabeculoplasties, who had other inflammatory eye diseases, in whom we could not get a proper tonometry reading and who were using steroids. During the initial visit, we measured the systolic and diastolic blood pressure. We measured the pulse rate. We calculated the ocular perfusion pressure using this formula. We did a detailed slit lamp examination, a gonioscopy examination, and a fundus evaluation. We did a field evaluation. We calculated applanation tonometry measurements, and we did a color Doppler imaging. And then the recruitment of patients were done in the glaucoma clinic. The patients were randomized into two groups by the glaucoma consultant, and the medicines were started. Every alternate patient was given temolol, and final CDI measurements were taken at 12 weeks. So our study group had normal tension glaucoma patients, and they were randomized into two groups, timolol and dorzolamide, and we did a baseline CDI, and then we did a CDI after 12 weeks. So the results. So we had it was a small pilot study, and we had 11 patients in both groups, and we compared the resistive index pre and post treatment in the 3 important arteries. So what did we observe? We observed that the resistive index was not significant with both drugs in central retinal artery and ophthalmic artery. However, we found a significant reduction in resistive index in dorzolamide group in short posterior ciliary artery. Literature says short posterior ciliary artery is very important, in particular to optic nerve circulation, and any insufficiency in short posterior ciliary artery can affect the optic nerve perfusion. So, so dorzolamide could be one of the probable good drugs in treating normal tension glaucoma, or in patients wherein there is progression of glaucoma in normal tension. And we also observed that there was a slight increase in peak systolic velocity and end diastolic velocity in all the groups, in the dorzolamide group. So coming on to the discussion, the vascularization of the outer zone of retina. Outer zone of retina is directly dependent on the posterior ciliary arteries, which is a branch of the ophthalmic artery, and any insufficiency in that can affect the optic nerve perfusion, and that can cause progression of glaucoma. But it is very difficult to detect the color Doppler imaging of short posterior artery. It requires little skill. The central retinal artery and ophthalmic artery can be easily assessed, but short posterior artery needs a little more skill to detect. And it's been reported in the literature that a decrease in ocular perfusion pressure and a decrease in flow velocities can cause progression. Similarly, an increase in resistive index can cause progression of glaucoma in susceptible patients. Therefore, color Doppler imaging can be used to prognosticate high progression risk. Kaiser et al. Had reported that in normal tension glaucoma, the retrobulbar hemodynamics is more important, and 72% of the published studies on dorzolamide has documented that it increases the blood flow. And the reason for increasing the blood flow is because of extracellular acidosis and selective inhibition of carbonic anhydrase inhibitor. And from our study, we found that there was a significant reduction in resistive index. That means when the resistive index decreases, the progression can be minimized, and it improves the peak systolic velocity and end diastolic velocity. So to conclude, perfusion of the optic nerve head is dependent on retrobulbar circulation, and resistive index can be a prognosticative marker in uncontrolled glaucoma and normal tension glaucoma. As sir said, we need not do a color Doppler imaging in all patients, but in patients whom we find progression in spite of maximum medications, and particularly in normal tension glaucoma patients, we can definitely consider this tool as one of the armamentarium to find out the reason for progression. And dorzolamide can be considered as a drug of choice for patients with normal tension glaucoma. These are my acknowledgements. They have helped me in many ways during my study. And we have few publications in that. This is my team where I work. Thank you.
Pratibha, you come and sit here. So Pratibha, do you have specific cases where you started dorzolamide and then things became better for the patient?
So theoretically, yes, the resistive index.
On mic.
Theoretically, yes, the resistive index had improved, and visual field changes. Visual field changes I haven't observed, but
Yeah,
the
so I think
resistive
you have already got those patients, and it will be good to study them in long term.
we have to follow
You know,
those
then we
patients
can
in long term.
100% prove now. Right now, you have one parameter which says that yes, things are better, and we are very, very happy because we all glaucoma as treating, everybody is treating glaucoma, and we are so fed up that sometimes we have given everything, things are not improving, so we want to do whatever little we can do for the patient. So definitely this does open our eyes, and we feel that yes, maybe if we add these kind of medications, our flow would increase. But just a thought, why did you use beta blocker in NTG, which is not normally the given drug?
Sir, there were some studies which had reported that temolol also increases blood flow. So we wanted to compare both the drugs and see which one is better.
Okay, fair enough. So we will discuss later, but now we have Dr. Sunita, and she's one of the finest surgeons available. She is head of Shroff Charity Eye Hospital in New Delhi, and she does so many other things besides that, like quality control, etc. But we'll catch her today for telling us what are the newer medications available. Please.
Thank you, Dr. Harsh, and I would like to thank CIPLA for giving me this opportunity. I'll be talking on insights on newer drugs for medical management of glaucoma. So glaucoma is characterized by optic neuropathy and associated visual field loss, and the prevalence of glaucoma, POAG, is 3.54 between the age of 40 to 80 years, and it is increasing and is expected to affect 111 million people by 2040. So elevated IOP is a major risk factor for glaucoma, and lowering of IOP is currently the only treatment available. So although both laser and surgical therapy are available, topical therapy is generally what we consider as first line of therapy for both ocular hypertension and open angle glaucoma, and even for angle closure glaucoma after PI. So if you go through the medical management algorithm, we start our treatment with a monotherapy, which is generally the PG analog, and if the target IOP is not achieved, then we add a single agent to the monotherapy. And now we know that 70 to 80% of the patients after 2 years require more than 2 therapy. So we have a lot of fixed combinations which are with, most of them are with timolol, and then we also have a combination of brinzolamide and brimonidine. So we can add any of these combination to the PG analog, and PG analog are also combined with the beta blockers. And once we have achieved the maximal tolerable medical therapy, and even if the target IOP is not achieved, we go in for surgery, either trabeculectomy, or now we can even perform MIGS procedures. So as we know, most of our drugs which we use in the management of open angle glaucoma are either aqueous suppressants or outflow facilitators, which are mainly improving the outflow of uveoscleral outflow. As we know, the prostaglandin analogs, they improve the uveoscleral outflow, or some may act by dual mechanisms. However, most of the commonly prescribed drugs, they do not specifically target the underlying cause of elevated IOP, that is decreased trabecular outflow pathway. So we know that there is a decreased facility of outflow of the trabecular meshwork, and none of the drops they target this pathway. And there was no new class of anti-glaucoma drug which was introduced for more than 20 years, but now we have different drugs, and the goal of development of new drug formulations or classes include their ability to improve the efficacy and duration of action of the current therapies, and with a favorable adverse event profile that minimizes the ocular and systemic toxicities. So you must be aware of the drugs which have been introduced in the last decade, and we have now Rho kinase inhibitors, ripasudil and nitarsudil, which are available in India, and we do not have the other drugs which are available in other countries, like latanoprostene, Bunod, which is the nitric oxide donating PGA, or E2 receptor agonists, and a combination of nitarsudil and latanoprost, which looks quite promising. So I am going to discuss about the Rho kinase inhibitors. So what is the role of Rho kinase over the trabecular meshwork? As we know, oxidative damage, stress associated with aging can lead to activation of ROCK or Rho kinase in the trabecular meshwork cells. They are present throughout the body, and in the trabecular meshwork, they cause contraction of the trabecular meshwork and production of excess extracellular matrix, and which causes decrease in the aqueous facility, outflow facility. So the Rho kinase inhibitors relax the trabecular meshwork and reduce the extracellular matrix production and increase the trabecular outflow facility and IOP reduction. And they do it by relaxation of the trabecular meshwork. So the benefits of ROCK inhibition in glaucoma is they may act in 3 different ways. One, as I already described, they improve the facility of the trabecular meshwork outflow. They also increase optic nerve blood flow, and they also thereby increase the retinal ganglion cell survival by improving the optic nerve blood flow, and thereby they have a neuroprotective role as well. Also, they decrease the fibrosis because of the fibroblasts, and when we do our glaucoma surgery, most of the trabeculectomy failure is because of the increased growth of fibroblasts. So they can be used as wound modulators post-trabeculectomy and reducing the bleb scarring. So now talking about the 2 commonly used drops which are available in India. Ripasudil, 0.4% eye drops, and it is used as twice daily dose, and as far as efficacy is concerned, it is effective. It reduces the IOP by 3.7 millimeters, and it is effective across all ranges of glaucoma, POAG, PACG, pseudoexfoliation, steroid-induced, etc. And it is additive to timolol and latanoprost. So these are the most commonly used drugs, and these are additive to both. And current research indicate that they have, as I have already talked about, that they have a role as neuroprotector, increased blood flow, anti-inflammatory, anti-scarring, and decreased macular thickness, and changes in the corneal endothelial cells. So as far as safety is concerned, we have been using these drops for the last 2 years now, and we do experience hyperemia. So these drugs have the propensity to cause hyperemia, although the hyperemia prevalence is more, 50 to 60%, but it is milder hyperemia, and it disappears after discontinuation of the drug. And it can also cause allergic conjunctivitis, blepharitis, and punctate keratitis. Another drug is nitarsudil, which has dual mechanism of action, and it is used only once a day as opposed to the ripasudil, which is twice a day. So as a dual inhibitor, it is ROCK inhibitor as well as norepinephrine transporter, and therefore it's a potent inhibitor of both ROC isoforms, ROC1 and ROC2, and it's a pro-drug. So it gets converted to its active metabolite, which is nitarsudyl M1, which has five-fold greater inhibitory activity against both ROC1 and ROC2. As
Sunita, just 1 minute.
yeah.
So if I have to use netarsudil or ripasudil, which one would you give me that, okay, you use this one?
So we have been using both, but what I feel personally is that the side effects are more with nitarsudyl.
Okay.
In terms of it not only causes hyperemia, but side effects related to cornea. It can cause corneal edema, cornea verticillata also. Although all these side effects are reversible once you stop the drug, they reverse, but still they cause more side effects.
And
But
if
some of the patients tolerate it pretty well.
better.
Yeah.
Plus it is an OD dosage.
It is an OD dose, so if you give it in the night, then the
yeah.
hyperemia will not be observed that much.
But if there's a corneal problem, would you like me to give ripasudil first? Because sometimes they say that it...
Actually, there are paradoxical reports because it has been used in Fuchs corneal dystrophy.
Right.
And wherein they say that it is beneficial.
Yeah.
But the studies have shown that it diverts fluid from stroma to epithelium. And that is why it can cause epithelial edema. And the other thing, cornea verticillata is also common with this drop. So although the prevalence is not that much, but still some patients who have compromised cornea, I think we should use with caution.
Okay.
But I have not observed that many side effects with ripasudil.
Right.
But as you said, since it's OD dosage, so we are, the patient is more compliant if there's no hyperemia.
You take your time. There's no...
Okay. So it lowers IOP by 3 different mechanisms, as I said. So Rho kinase inhibition by relaxing trabecular meshwork, norepinephrine transport inhibition, which decreases the aqueous humor formation and thereby by causing vasoconstriction of the ciliary body. And it activates the noradrenergic receptors, which prolongs IOP reduction. And it also has vasodilator effect, which decreases the episcleral venous pressure. So that way, in patient with Sturge-Weber syndrome and all, which have high episcleral venous pressure, because none of the drops act on episcleral venous pressure. So it has an application there also. So it has multiple, mechanisms by which it acts. And as far as side effects that we were discussing, this is the efficacy, and the percent IOP lowering is, sorry, I'll take 5 minutes.
No problem. Go ahead.
So 15 to 22% if it is used in OD dosage, and 16 to 21%. So these are the 2 studies, Rocket 1 and Rocket 2, where the drug was compared to timolol. And once daily dosing of nitarsudyl is found to be very efficacious with lower side effects as compared to twice daily dosage. So as we have already discussed the side effects that it can cause adverse side effects like cornea verticillata, and sometimes there is pain during instillation, conjunctival hemorrhage also. So we have noted in very few patients very small petechial hemorrhages, and cornea verticillata occurs in 20% of the patients in controlled clinical studies, and it was noted in one of the studies after 4 weeks of daily dosing, and but it was mild with no associated decrease in visual function. So even if there is cornea verticillata, the visual function is maintained. So patient doesn't complain that much. The patient is more bothered about hyperemia than cornea verticillata. And
so anyway, Sunita, in these drugs we are using literally as a last resort.
Yeah.
Okay, I think all of us understand that. So वो time ये होता है कि we say कि okay नहीं तो we'll do a trap. तो वो कहता है सर redness ही चलने दो. So yeah, that is what it is. It is the last drug. And do you agree that the beauty of the drug is that even when everything else is acting, and normally they say that if you add the 4th drug, its effect is going to be quite less. But this sometimes works wonders.
Yes.
Do you agree with that?
It is additive, definitely,
Yeah,
because
so
most of my patients, at least, they are very advanced glaucoma with very high pressures.
all of our.
And you have to, yours also. So we have to give maximal medical therapy. And if you combine, what I do generally is I combine PG analog and timolol if the patient is systemically
Yeah.
healthy, brinzolamide, brimonidine, and then nitarsudil or ripasudil, whatever you like.
Yeah, yeah,
So
good.
most of the patients who have very advanced glaucoma, you have to combine all these.
Absolutely.
So I will not go
Leave the
into
trials
detail.
and all, just
And now I think we are looking forward to this combination, nitarsudil and letanoprost fixed dose combination. Although I am expecting more side effects because both the drugs cause hyperemia. So I don't know how it's going to fare in terms of side effects, but in terms of mechanism of action, because letanoprost improves the uveoscleral outflow and this improves the trabecular outflow. So I think they will be really synergistic,
yes.
and they will have definitely a better IOP lowering. But in terms of safety, the studies have shown that the side effect wise, I think it is as good as using nitarsudil only. So
Oh. Yeah,
then,
foreign maybe. Talked to a couple of my friends.
yeah,
The Rocklatan that they started, the combination of this has
yes.
not really picked up. So sometimes I really feel, because you ask any company, they will say, yeah, the combination of the drug is as good as giving them separately.
Yeah.
But I personally, whenever we are at the brink, I would rather give them separately so that you have a greater this.
No, but
Plus,
if
the timing
but
is
if
different.
you have to give 5-6 drops,
I
then
know,
it may
no,
be
but these
difficult
are the
to give them
patients who are
separate.
going for surgery otherwise. So they bloody will put it 10 times if you don't want to do the surgery.
So I think this is the last one. I think nitric oxide donating prostaglandin analog, that is letanoprostin bunod. So again, I think this is a very good combination and it's in pipeline, and it has dual mechanism of action. It acts strongly on both aqueous outflow in contrast to conventional PGA. So anything like, because PGAs are the main treatment which we're using, and if we have any drug which improves the trabecular meshwork outflow, then I think that is most welcome in our armamentarium. And this drug is hydrolyzed. Again, this is a pro drug, so it releases letanoprost acid and butanediol, and which is further metabolized.
ये available है कहीं?
It is not available in India, but it is available otherwise outside.
Okay.
It has already been. So nitric oxide relaxes the trabecular meshwork cells and facilitates the trabecular meshwork flow like nitarsudil, and it has been hypothesized that markers for NO are decreased in aqueous humor, and that lowers the NO level may contribute to increased IOP. So if we have nitric oxide in a drug form, then it will definitely improve the trabecular meshwork outflow and decrease the intraocular pressure. And it also regulates ocular blood flow and may promote retinal ganglion cell survival. And efficacy wise, I think it is better than PG analog, and it has high tolerability and compliance. And nitric oxide has a very short half-life, less than 3 seconds. So therefore, it is highly unlikely that it will cause toxicity of retina. So I think that's a plus point here.
Okay.
And these are the other molecules which
I'll
I'm
leave
not
that.
going to,
Leave all those because they are not.
Okay.
What is there? We'll talk only about that. So anybody has a question for Sunita, because she'll now run away. So don't ask me behind. I may or I may not know. Anything about ROCK inhibitors that you want to ask Sunita, please catch her now. What is the half-life? If suppose you want to give a washout to these drugs, what is the expected this thing? Any clear idea?
I think not very clear.
Not, I
No,
think
no.
there's
I
actually
think we
this
never
is still in
talked
work
about
and
this
we have
at
not
that.
really done too much work on it. So these are the basic things that we know. Thank you, Sunita. Thank you very much. Oh yeah, good question.
Yeah,
I
think
was
that's a
actually
very
had
good
written it and to
question,
ask that.
because
Have you actually?
theoretically I think it reduces scarring. So if we have
No,
to
have
use,
you done it and
no,
have?
I have not done it, but I think we should.
But we can try. No. Yeah, it is too early for us, but if she has theoretically written it, again, like half the things we are doing because theoretically they say it works. Actually, क्या हो रहा है किसी को नहीं पता. But ठीक है, there's no harm. No, both, both,
Reticular
both occur.
edema.
Both
That is
occur. We have seen
reticular
both.
edema because the fluid shifts from stroma to
Epithelium.
epithelium. So that is also seen. I have seen in 2-3 patients.
Yeah, yeah, yeah.
Verticillata is different.
Yeah, yeah, yeah. But the moment you stop,
Yeah.
within 2, 3,
So
4 days, they are gone. So we are fine with that.
Yes,
But
yes.
yes, you are right. Both the things can occur actually. Microcystic and
cornea
verticillata.
surgeons, they use it for fuchs atrophy and all.
Yeah, that is the. Uh-huh.
Yes. Netarsidil.
Actually,
Not with repasudil.
repasudil is said to be
So
more protective
yes.
to the
So
cornea.
I prefer still, if a patient can use it 2 times, and I prefer repasudil because
Okay.
the side effect
Purvi,
profile
chalo.
is better.
हाँ.
It
It
is
is
used as
used.
3rd or 4th only. That is
And fifth also.
no. First is PG analog. Second is either dorzolamide
Timolol.
or timolol or brimonidine, whatever you like.
Then dorzolamide, then this thing, and if pilocarpine is available, then pilocarpine, then this.
Yes. Thank you. Thanks a lot.
Thank you very much, Sunita. That was very nicely done. And कुछ होगा तो मैं phone कर लूँगा तेरे को. Okay, so we now have Purvi, and she is with the crux of the matter. Preservative-free therapy for all. So I think that's a very tricky question, and Purvi has to really answer us on that, because the trouble is that now people are coming with preservative-free medication, and now we are lucky that Cipla has come with everything preservative-free, literally all the medications. So definitely we love it, but is it required, and how often should we use it? Because the costing is an issue. So Purvi, please clarify for us.
Thank you, sir. And I would just like to state that though this is a sponsored session, the content of my this presentation is purely academic and scientific.
So she has no interest in that. And I'm really sorry, but she's an associate professor and head of glaucoma clinic in Ahmedabad.
Yeah, professor now, sir.
Now professor, my God.
So the content of my presentation would include a small overview about the glaucoma and ocular surface disease, the role of preservatives, the problems specifically caused by benzalkonium chloride, and finally what we are interested in is the finding solutions to these problems. So it has been known through literature that about 39 to 75% of the medically treated glaucoma patients, they do report some form of an OSD symptom. So what is the relation between glaucoma and OSD? Both of them can actually be prevalent in the elderly and exist as common comorbidities. There is a role of the active ingredient, that is the anti-glaucoma molecule per se, in the development of OSD, and there is a role of the preservative agent, particularly benzalkonium chloride. It has been found that even untreated patients of POAG, they have a 27% reduction in their basal tear secretion compared to healthy controls. There is a significant association between pseudoexfoliation and dry eye. Pseudoexfoliation actually influences both the quantity and the quality of the tear production, and of course we know that it affects the conjunctiva and the surface. And immunological components have been identified in glaucoma as well as Sika syndrome. Coming to the active ingredient itself, timolol, we have been knowing since years that it does have a detrimental effect on the ocular surface. Prostaglandin analogs, they are pro-inflammatory as such, so they definitely have an effect on the ocular surface. And studies have now shown that the long-term use of prostaglandin analogs, it also causes obstructive meibomian gland dysfunction, so which ultimately leads to ocular surface disease. Brimonidine, we know again it is a notorious drug known to cause follicular conjunctivitis. Cholinergics are again pilocarpine, we know it is a pro-inflammatory drug. And the Rho kinase inhibitors, we still need data on this, but it does cause significant amount of hyperemia, which perhaps in the long term may have some effect. Number of studies indicate that the chronic application of eye drops does induce cytological and histological impairment in the ocular tissues, and preservatives are the chief culprits. So why do we need preservative in the first place? They are needed for the sterility in the multi-dose formulations. They are needed to stabilize the medications, and they were said to help in the promotion of the drug through the cornea, which is actually questionable. The ocular tolerability of all these preservatives, it depends on the concentration, combination, and chemical purity of the preservative, the frequency and duration of the drug, and the inherent state of the cornea and the ocular surface. So what are the types of preservatives that are available? They are detergent, oxidative, chelating agents, and metabolic inhibitors. Out of these, in the anti-glaucoma formulations, only the detergent and the oxidative types are used, so I'll discuss only on those two. And in the detergent, we have the benzalkonium chloride and the polyquad. In the oxidative, we have the stabilized oxychlorocomplex, sodium perborate, and the ionic buffer system. So let us see how each of them have an influence. Benzalkonium chloride, it is a quaternary ammonium with a detergent action. It dissolves the bacterial walls, membranes, and damages the cytoplasmic contents of the organisms. Now the problem here it is the molecule itself is very, very small compared to the human cells. And therefore it also damages the normal human cells. It causes tear film instability, it affects the mucous layer of the tear film, it affects the lipid layer of the tear film, therefore causing evaporation and dry spots. It causes loss of goblet cells, metaplasia in the conjunctiva to the extent of causing apoptosis. It disrupts the corneal epithelium barrier, thereby penetrating inside the eye and even damaging deeper ocular tissues. And studies have shown that actually it can reach as deep as to the trabecular meshwork as well. It leads to an increased release of the inflammatory markers and is also known to cause allergic reaction by itself. Polyquad is also a detergent, but its molecule size is 27 times more than that of BAK. So it cannot damage the normal human cells, and therefore it is, though being a detergent, it is a safer one. Coming to the oxidative variety, SOC, which was earlier patented as purite, it breaks up into non-toxic components. Sodium perborate also gets broken up into non-toxic components like water and oxygen. And the IBS, which was earlier patented as Softgia, the ionic buffer system, which a lot of anti-glaucoma drugs now have, it again contains non-toxic and totally benign and harmless ingredients. But BAK, unfortunately, is the most commonly used preservative in overall in ophthalmology and is most toxic than all of them available. Its side effects are dose dependent as well as time dependent. And this was a data we have collected through the market survey, and I'll mainly restrict the screenshot with respect to the preservative. So you can see almost all the individual molecules as well as the FDCs. Most of them contain BKC in some form or some concentration or the other, which could range from 0.003% to as high as 0.1%, which could be actually necrotic to the normal tissue. This is a study which we had done at our center in 2018-19, studying the safety profile of different anti-glaucoma drugs. And the most common side effect that was noted was dryness and redness. If you see the comparison of drugs having BAK versus those without BAK, TFBT and the Schirmer's test were significantly affected in all those eyes which were exposed to BAK containing drugs. And again, if you see those patients who were exposed to BAK, 55% of them required some form of an additional lubricant, whereas in those without BAK, only 2 patients needed an additional lubricant for their dry eye. If you see the global scenario again, lots of studies have been done which study the effect of BAK on the ocular surface and specifically in relation to the anti-glaucoma drugs. And overall, the conclusion of these studies is that the tolerability of anti-glaucoma medications decreases with increasing age, increase in the number of medications, duration of the therapy, and the presence of benzalkonium chloride. So what is the impact of OSD? The symptoms, of course, all of us know it could be something as simple as and vague as dryness, burning, irritation, to something more severe as effects on the visual acuity, ultimately causing a substantial impact on the patient's quality of life. And of course, we know that the chronic inflammation of the ocular surface, it does affect the surgical success of our filtering surgery. It has also been studied that one of the most common reasons for non-compliance is development of ocular surface disease. This was a patient who presented to another ophthalmologist, and he kept going back to the ophthalmologist with this kind of an edema, conjunctival congestion, and a severe periocular dermatitis. The ophthalmologist thought that this is an anti-glaucoma molecule to which the patient is reacting, and they kept changing the drugs. And finally, incidentally, the patient turned out to be a relative of a pharmacologist. That faculty referred to us, and studying all the medications that the patient had, we could finally conclude that actually it was BAK which was common in all of them, and this was actually induced by BAK. And the patient then simply refused to use any drug because he became very panicky. We did SLT in the patient, and finally the patient was off all the drops, and the allergic edema and all that dermatitis resolved. So BAK is definitely an added threat to glaucoma patients. The key to this problem is prescribe the simplest regimen which you can to your patient. Use fixed dose combinations when possible so that at least the preservative load can be reduced. While you are managing your glaucoma, also watch for and treat the simultaneous OSD if it is there. And talking of the main question, when would you go for a preservative-free therapy? There are specific patient profiles where you should definitely consider this. One is, of course, if there is an inherent and pre-existing OSD, pseudo-exfoliation, and if the patient is on a polypharmacy. Elderly, because overall even their ocular surface might not be so healthy and they are more sensitive to symptoms. Women, especially on hormonal therapy and in the perimenopausal period. Contact lens users, those who are exposed to an environment which puts them at a risk for OSD, and of course those who have an allergic tendency. While treating the OSD in glaucoma, also remember that the patient, if they develop a dry eye symptom and you add a lubricant, and that lubricant also has BAK, it is only going to make your matters worse. So whenever adding lubricants to these patients, also see that it is BKC free. So when would you add a BKC free lubricant? When the frequency of the lubricant needs to be more than 4 times a day, there are measurable signs of dry eye, and when the dry eye is in the moderate to severe category. And of course, there are non-preservative options also. You can consider single dose vials, that are the unims, where no preservative at all is included, but of course not very convenient, very expensive, not freely available. And other options, non-medical, that is an SLT going for an early surgery, and of course the under research, that is the drug delivery systems. So to conclude, OSD and glaucoma commonly coexist. OSD is influenced by the duration of therapy, number of drugs that the patient is using, type of preservative. Most anti-glaucoma drugs contain BAK, which is responsible for toxic and immunoinflammatory effects on the ocular structures. Preferable to prescribe BKC drugs in select cases, and a careful OSD management will ultimately improve the compliance and therefore help in your glaucoma treatment as well. Thank you.
So, thank you, Purvi. That was wonderfully done. And so the question is, when would you suggest to these people that they should go with a preservative-free medication? So suppose they're using Dorzox. Now we have Dorzox PF. So when would you say should if the patient can afford, do you want all of them to be shifted?
No, sir. As I said, if the patient is doing fine, has no complaints, you cannot see any effects on the ocular surface, not a single
No,
vague
I mean to say
then we can continue.
he's
on
a
PKC.
first time patient, and anyway we have to start dorzolamide, suppose in addition to other things. Would you, and he is a good affording patient, shall I give PF or should I give routine Dorzox?
You can give a routine drop.
We can give a routine drop only when they start complaining that there is
Yes,
something
yes,
problem.
yes.
But once the complaints start, don't you think already the conjunctiva is compromised?
Yeah, so we have to keep a watch, as I said, along with your glaucoma management.
if the
every
patient
time
is
you have to see the ocular
if
surface.
the patient
and
is
see it.
affording, then what is the harm?
There's no harm, but there's no harm in doing it the other way also.
No, but why do you want to wait till something? Yeah, please.
Consider the age of the patient,
Age is nothing now. People are dying at 40, and the ones which are at 60 are living till 90. So, huh. So I think the Andaman Nicobar will give the final opinion.
But sir, we have to keep in mind that affordability needs to last for the
Yes,
lifetime.
yes. That is what we are saying. That
Yes.
to my mind, what is your take?
That
Pratima?
affordability needs to last
Let us,
lifetime.
sorry?
That affordability needs to last for the lifetime. It's not a
You
one-time question.
No,
of
no,
buying
no,
that
fair. How
expensive
do you know
product.
there everybody has crores here? Purvi, don't worry. There, you can get a economy class ticket, you cannot get a business class ticket. This is India now, new India. No, no, but she's right. Well, see, we got the picture, but I think, or the better thing would be to, what is your take?
Sir, I feel that we start with a normal
Normal. The girls are very soft. They do not want to spend any money or the.
probably do a dry evaluation if the patient.
Oh, yeah, by the time patient comes or he doesn't come, there are too many things. I think we should give the option to the patient. I think it is fair enough. And okay, fair enough. I think the crux is that we can explain to the patient that these are 2 drops available. This is the difference in the cost, and if they are willing for it, then definitely they should go for that. If it is not, then like Purvi said, we do now in most of our glaucoma clinics, the patient basically goes for a basic dry eye workup. Okay, so fair enough. Uh, should not be. Is there any, Purvi?
No, no. Studies have actually been done to compare the efficacy also BKC free and BKC containing, and no difference in the efficacy has been found.
So that is really funny. You are right, because one of the drugs said that we are increasing BKC so that the penetration can be more. Right. So we were also very confused. We had a big discussion. So what do you say, Purvi?
No, actually, that role is now questionable, that whether it at all has any effect on the penetration. Because on the contrary, the penetration of the BKC itself is what we don't want. It should not be going into the eye. Yes, yes. But now there are a lot of non-BKC drugs, and studies have been shown, and literature shows that there is no change in the efficacy.
Okay, fair enough. Actually, it. I think that's a brilliant idea. That's a very, very good idea. यार ये हमारे दिमाग क्यों नहीं चला? तो very good. So if we are having two eyes, sorry. Yeah, may not, but at least the patient will know that if there is a significant difference between the two, by 2 months, you can do it for 6 months. But at least he is having that. I think. What do you say, Purvi?
Yeah, but then we just
You
need
can
to
give a
ensure
thesis.
that the
You can
patient
give a thesis
always-
on this.
Yes, sir. Definitely good idea. But we just need to ensure the compliance, that the patient is always using one drug in one eye and the other.
Yes,
There should
he
not
may be
a-
putting
yes.
one in and then crossing it over. No, that will not be a good idea. The good idea will be what you said initially. 1:1 simultaneous. That will really be the crux. That's a very wonderful suggestion. I really never thought of that. That's a good idea. So if we are both having both these things. So another thing is that whenever we put dorzolamide, a lot of patients immediately sir अरे ये तो लगता है, ठीक है ना, because of the pH thing. So Purvi, would you like to give a lubricant 10 minutes before that, or what do you do, or you change over to brinzolamide or something like that? What do you do in these
No,
cases?
actually we don't add anything for that. We just counsel to the patients that this is going to happen because it is drug related, but the drug is necessary and you just need to ignore. Only if the patient is very, very panicky and non-hesitant, then we actually change the drug, but otherwise we don't add anything for
Right. उसको बोलना है यार बिल्कुल दवाई असली है. Then he is very happy. हाँ यार
चलेगा
लग रहा है
तो
ना
काम
सही है
करेगा.
दवाई. तो yeah, that is what we are saying. You see, it is so not everything. The preservatives have come in a big way, but yes, all of us agree that there are sometimes patients who are having hell. You change them over to preservative-free medications and they become better. I think all of us have seen that. So I think it is worth a trial for all these things. Anybody has a question on that? Are you convinced that dorzolamide, suppose I give you a choice of dorzolamide, using dorzolamide or brinzolamide, what would you use?
Sir, in this
Loaded
simple-
question, she'll not answer.
in
That's
this
a very
simpler
low.
session, I don't think it
Yes,
would be
not in this
appropriate to-
session. But please, for God's sake, teach them punctal occlusion. I get millions of patients from thousands of places, and I can promise you only 1 out of the 100 have been taught punctal occlusion. With folded hands, I want to tell you, spend some time with a new patient, spend 10 minutes. Ask them who they are, what is their income. You don't have to ask. In Indian Aadmi, you just have to say, kya chal raha hai? And they will come out with everything. Okay, so then you can judge whether he can afford, whether he cannot afford, what medication, should you give a PG, should you give a TIMO only. Okay, sit with him, explain to him कि भाई हर 2 महीने बाद pressure कराने आना है. Every 2 months you need to come for pressure. Every 6 to 9 months to 1 year you have to come for field test. And if this happens, I promise you that you'll keep seeing till you go. This last sentence is a must, which many of the youngsters are missing out. Please don't do that. He has come there not for a scrap of paper, not for a medication. He has come to be healed. And that is one thing that we completely forget. So punctal occlusion, these 4-5 things, this one sentence in the end will give a smile that you will never forget, because they are so scared that they'll go blind in their seeing time. Okay, and another important thing which Ramakrishna taught me, that take the bottle, hold their hand, tell them how to put the drops. It gives a physical contact. Obviously, COVID, we had a problem, but now that thing is pretty behind us. So you will be surprised how so many of them just don't know how to put the drop. So please tell them that, and tell them how to do the punctal occlusion for how long, and so they, yeah, very good. Opening se zyada closing. You know what they'll do is, I always tell them, bring like this, bring close and then close. Otherwise what happens, they are bringing from here, invariably the tip will touch the thumb or something. So the closing part is the one which will get infected if they are touching somewhere else. So how they are closing, how they are opening, how they are putting, who will be putting the drop for them. Okay, and if they are generics, sometimes people are very, very against generics which are much cheaper. So yes, we are against, but because their droppers are not good. So you check how many drops are coming out. Yes sir, you were saying something. Exactly, that's what I'm saying. You have to check with this. You have to tell them, please, only one drop. How will you prevent allergy to the skin? My patient only taught me. You learn so much from the patients. So he said, sir, before I put anything, I put a cream around my eye. So kahan jayegi skin pe? So, and all, please remember, PG analogs, the black part, the periorbital, this thing which occurs is because the skin pe wo lagta hai. There is a paper by Dr. Cook. So the moment you can put a cream and close and just wipe it off so that it doesn't go on the skin. You have to tell them only the capacity of drop is, the eye is less than one drop. So many of these small things we are not telling to the patient. So the first time a patient comes, it is this thing. And what one very, very more important thing has to be told? Anybody? Sabse important thing. अरे यार, get your family checked. अरे तुम्हारे क्लिनिक में और 20 पेशेंट आने वाले फ्री के, यार तुम भी यार क्या यार, ठीक है ना. सो उसमें से कई तो लैजिक करा लेंगे तुमसे, क्या प्रॉब्लम है. सो ऑल द फैमिली, दिस इज द ओनली वे वी कैन कैच अर्ली ग्लॉकोमा.
Or just add something?
Yeah, please.
Yeah,
please.
to that demonstration of the installation technique, actually what we follow, and of course we do have the student manpower, but we follow the teach back technique, because sometimes just telling them how to do is not enough. They may not have understood. So we just demonstrate what is to be done, and then we, in our presence, we ask them to show what is to be done. So we can rectify there and there if anything is wrong. So
Absolutely, absolutely. It has to be seen how they are putting it. So the consensus, please.
What age will you advise to the patient that if they have got kids, if you have diagnosed the case of glaucoma is 45 years of age, you obviously have to tell them that your kids also might be having this.
Yeah.
So what minimum age will
Anyway, most of the kids are now getting glasses. तो वो 4-5 साल का भी है तो उसको बोलो भाई एक बार आ जा, ठीक है ना. बट बी वेरी वेरी केयरफुल, बिकॉज लॉट ऑफ दीज kids may be having physiological cupping, and then they are subjected to a lot of nonsense. So, and you are trying to take a pressure, they'll just cover like this, and the whole thing will just it'll become 50. So the taking a pressure is an art, especially in children. I think our time is over, and thank you very much for a wonderful being here. Thank you very much. Thank you, Purvi. Thank you, Suja.